Welcome to this introduction to realist evaluation aimed at early career researchers and those new to realist methodology. So today we're going to look at some of the terminology around realist evaluation, the underpinning theory, and we've got two worked examples, a realist synthesis and a realist evaluation. And for the latter, I'll be joined by Graham, who's a lay advisor and worked on that project that ran for a good 3 years. Why might you use realist research? So realist research comes under the umbrella of implementation science. So we're looking at complex interventions. So for example, community-based rehab, where you have several disciplines involved, like occupational therapy and physiotherapy. You have different variables in your treatment, and you have different variables in the home that you're entering. The person might live alone, they might have good social support. There's all sorts of things that will affect how your intervention works. So we need to understand the behaviour of people, whether that's professionals, patients, carers, commissioners, and how that affects the sustainable uptake, adoption and implementation of evidence-based interventions. In other words, people have agency and they might not do what they're supposed to do or what you expect them to do. We have to take account of all of this and then think about how do we integrate what we found into policy and practice so that it actually makes a difference on the ground. Realist evaluation is based on this. It sits under the umbrella of implementation science, but it's very much explanatory and theory driven. So it really wants to understand what works for whom and in what context. The assumption is that the intervention has already been judged as worthwhile, but what you don't know is what exactly about it makes it work well in different circumstances. The aim is to develop and refine program theories or explanations about how and why interventions work or produce beneficial outcomes, including how and why they work differently in different contexts. So it also acknowledges that you may have unintended outcomes. Let's just revisit the continuum of what knowledge is and how do we find out what's true or not true. So we've got constructivism at the far right, the acceptance of multiple realities, usually qualitative design. And we've got positivism, think randomized control trials on your far left, where if you do A, you get outcome B. So nice and cut and dried. Realism sits right in the middle there. It addresses how and why questions, and it provides an approach to tackle the questions in an open setting. It's trying to understand why things are as they are, and it's particularly suited for that reason to interdisciplinary and health services research. Think back to your early lectures about Roy Basker and friends. Critical realism was a response to the dominant positivist paradigm. And there's lots of different branches, but in essence, probably the most distinctive feature is the belief that the world is independent of our understanding of it, and all knowledge is partial, incomplete, and fallible. So there can be different interpretations of a phenomenon based on your perspective. For example, a commissioner's perspective is going to be different to a carer's or a clinician's because they've got different aspirations and different agendas. Realism proposes that social phenomena exist in an open system where structures and mechanisms interact at different layers of reality. And there's always that constant state of flux, so things are always changing. And this leads nicely into the iceberg metaphor. I'm going to assume you've got some knowledge of Basker's stratified ontology, where mechanisms, events, and experiences constitute three overlapping domains of reality: the real, the actual, and the empirical. What's important is the complex interaction between this dynamic, open, and stratified system, where particular structures give rise to certain causal powers, or what Justin Jagosh and the realist camp refer to as mechanisms. Jagosh uses the iceberg metaphor in most of his courses, and you can see that you've got what's below the surface, this hidden context, and underpinning mechanisms that may or may not get activated. What's above the surface is what we observe when we're doing our research, and it's the result of those underpinning mechanisms in a certain context. So how a mechanism is manifested or not is contextually determined. So the same mechanism could produce different outcomes, or different mechanisms may result in the same outcome depending on the context. This is very different to your positivist A leads to B, and really aim to identify tendencies at the real level and contend that what causes something to happen has nothing to do with the number of times we've observed it happening. So again, that's different to your randomized control trial. But let's have a look at how this translates into the realist camp CMOs, or context, mechanism, and outcome configurations. The context is the elements in the backdrop environment of a program or an intervention that have an impact on outcomes. For example, if there are significant recruitment and retention problems in an organisation, then that will affect service delivery. It might end up with a waiting list that will result in dissatisfaction in the people using the service. So a mechanism is a resource offered through a program in the way people respond to those resources. If you have a good training budget, that may boost staff satisfaction, leading to an outcome of better staff retention, well-trained staff, and good patient satisfaction. So your outcome is the intended or unintended effects based on the context mechanism interaction. Now, obviously, you're going to have lots and lots and lots of CMOs for any intervention, and it's trying to make sense of all those differing things that are happening all the time. The way that the realist camp tries to do this is through a process of retroduction, which is meant to overcome the shortcomings of induction and deduction to try to offer causal explanations. The idea is it's theory inspired by evidence, and it involves going back from below or behind, observe patterns to discover what produces them. So it's a bit of a creative, let's come up with a theory, let's test it out with more data, let's see if it holds. If it doesn't hold, we'll go back again. So it's very iterative, which also makes it quite hard and definitely not fast. When you build your theory, you come up with CMO configurations, so context, mechanism, outcomes, to generate causative explanations relating to the outcomes. So you're exploring the relationship between an outcome of interest in a particular context and trying to identify why it happens. So what is that mechanism? And the CMO configuration is a way of refining theory about aspects of the intervention, or the whole, it might be a wider picture of the intervention sitting within a service. Another very popular term you'll hear is program theory. Now, some people use CMOs and program theory interchangeably, but the party line is that program theory is the overarching theory of how a particular complex intervention may work. And it draws on evidence, data, and creative or retroductive thinking to seek explanations of how, why, and in what context an intervention works. Again, you may start with an initial program theory, which is usually quite a short paragraph before you've even done your literature review, or it may be part of doing a literature review to develop a program theory that says, if we do X, Y, and Z, then we think we're going to get these outcomes in these particular contexts. And that helps you get going. Bear in mind there can be multiple CMO configurations leading to what's known as a ripple effect. So one CMO may be embedded in another, or you can have this series in which the outcomes of one CMO become the context of the next in a complex chain of implementation steps. And then we want to look at a mid-range theory. So something that's a little bit more conceptual, that isn't specific just to this study, We might look at something around self-efficacy, if it's to do with behaviour. We might draw on something like normalisation process theory, where we're trying to look at why clinicians buy into a particular intervention or not. So you've got different levels of theory building and trying to fit it all together. So next we're going to look at realist synthesis versus realist evaluation. So realist synthesis is also called realist review, and it can be a rapid realist review, which is very similar to a full realist review, but you put some caps on your data collection. The actual analysis is just as long and painful. So it's secondary analysis. It's reliant on data that's already out there. It's usually an iterative process, and you would draw on grey literature, reports, anything you can get your hands on. And expert stakeholders are integral to the process. If you want to look at the full standards, they're there, Wong 2013. Realist evaluation, often based on a realist review, is your primary analysis of data. So quite popular study design is case studies and then mixed methods data collection within each case study. Again, it's iterative, but you're more likely to have time constraints. And again, expert stakeholders, that includes patients, carers, members of the public, clinicians, commissioners, whatever is relevant to your area of interest. As an example of a realist synthesis, I'm going to use a rapid realist review that I carried out with Wenjin Zhang at the start of lockdown. And I think we both agree that it wasn't hugely rapid. It's to do with autism service delivery for children and young people, and the rationale was the waiting times in the UK for autism diagnostic assessment. And when I say waiting times, I mean 2+ years. And the aim was to uncover current evidence base, what works best for whom and in what circumstances, to inform the current evaluation. We set fairly rigid parameters, so factors that contributed to clearly defined intervention, so the diagnostic pathway, associated with specific outcomes and within specific parameters. So autism diagnostic services in the UK either sit in paediatric services or CAMS, child and adolescent mental health services. And we had quite a large stakeholder group that included a wide variety of views and also a wide knowledge of grey literature. And the idea is that if you draw on their expertise, it does accelerate the search process, and it also helps to validate the findings. So you keep taking the findings back to people. I'm going to go through the stages of our rapid realist review and try to just draw out what differentiates it from a standard systematic review. And really the key thing is the iterative nature at every stage and stakeholder involvement at every stage, and drawing quite considerably on grey literature, whether that's from trust websites or reports or things on charity websites, anything and everywhere we looked. We developed and refined the research question with our stakeholder group, and we carried out a workshop. We also developed an initial program theory and carried out a background search to refine our inclusion and exclusion criteria. We then carried out a pilot search in PubMed in a standard format, and we did iterative secondary searches for grey literature. We also did some standard primary research looking for key authors in Google Scholar, forward citation. We did have quite a lot of grey literature, which is noteworthy, and we selected articles and screened them with a tool that we devised based on our inclusion-exclusion criteria, and we ranked articles as highly relevant, probably relevant, or not relevant. And the relevance mainly related to having a thorough description of the service delivery model, which ruled out an awful lot of papers. We then carried on to data extraction and appraisal, and that is different because we did a standard data extraction into an Excel spreadsheet, all the usual things, but we also put all the articles that were highly relevant, and that was, I think, 45 of them, into NVivo, and we coded them according to an initial framework based on our CMOs. That was, again, an iterative process, so we had to keep changing that. So we had about 129 grey literature that we whittled down as well. There's a lot of fiddling about when you're trying to code context mechanism outcomes, and you've got to think carefully how you set up your framework in NVivo. Sometimes it's hard to judge is something a context or a mechanism. So we took things back to the stakeholder group, which helped us refine our coding and also validate to a certain extent what we were coming up with. And we also did standard things to help with rigor, such as a third person calibrating some of the papers we coded. And whenever we were unsure about a paper, we again took it to the third person. That then led to syntheses, or building program theories, and comparing across with middle range theory. So we did use normalization process theory, and we had quite a lot of consultation with our stakeholder group. A lot of that was interrogating our findings to help us challenge to see did the data fit, or were we trying to shoehorn things in. And then we carried out a workshop with our stakeholder group to test and refine the CMOs and also relate to the mid-range theories. As an example of what a program theory might look like, here's the first one. This is the first one of 7, and each one had several parts. So if frontline health and educational professionals are confident in recognizing the signs and symptoms of autism, are cognizant of referral pathways, and take parents' concerns seriously, then children and young people will be referred to the appropriate service in a timely manner, reducing parental frustration. So that's quite a mouthful, and there's a lot that's gone into that. So you can see 1A, parents' concerns are listened to and discussed. You've got a breakdown of the CMOs and where they came from. And we could track back in NVivo to see exactly where it came from. And we also had our own tables, which we did in Word, which helped us to condense what was reams and reams of information at that stage. So we did that for every CMO. And then we tried to map it to see how did the CMOs or program series relate to each other. And you can see on this next slide, you can see at the top in the grey box is the context of autism diagnosis. And these are things that were very well documented in the literature, but are things that we already know. So they're not the focus. The focus is how do we make it better? What strategies or ideas can we pull out of the literature that would help? We divided by the stages of the pathway, so pre-assessment, referral and triage, diagnostic process, feedback and management. So each of those is a program theory with subcomponents, and within each subcomponent that's broken down into detailed CMOs and the literature that we got it from. And then the yellow boxes on the right are more global things, so things like working in partnership with families, interagency working, training, service development and evaluation. So those are all really big, and there was a huge amount of information. It is very hard to try and condense it and to pull out what's important, and that's where it's really, really useful to have your expert stakeholder group. This Realist review was used to inform the next stages of the process, which was Realist evaluation, and we used a case study design. And that brings me on to our next example, which is also a Realist evaluation using a case study design, but set in the context of hospice at home, end-of-life care. The background is that many people want to be able to die at home, and hospice at home services aim to support patients and carers to achieve this. And there's a range of services with some evaluation, but limited evidence synthesis. We aim to find out what models work best, for whom and in what circumstances, and it included a health economics analysis. The design was mixed methods and 3 phases, alongside which program theories and CMOs were developed. So I'm going to welcome Graham Silsbury to tell us about his involvement with the study as a lay advisor. Graham, could you tell us a little bit about the OPEL study and your involvement, please?
Yes, I was invited to be a member of the team, as previously I'd spent time caring for my wife. I felt being involved with this sort of work would be helpful for the development of hospice at home services. My actual background is in engineering, and so this sort of research was a new approach for me.
Okay, and what were your initial thoughts about the realist approach?
Initially, the concept I felt was relatively easy to understand. But with no experience, once the process started to roll out, there was far more to know before I could actively participate in the work. I thought that my opinion alone would be recognised by the group as valuable, and it was only after understanding the approach that I appreciated realistic evaluation is a process based on the evidence. Once my understanding improved, I could appreciate the logic, as well as the iterative nature of creating CMOs, and then testing and refining them. When, as a research team, we were analysing the interview data, it was so important that we challenged each other to refine the CMOs in a systematic and realistic way.
Thanks, Graham. That leads nicely into thinking about rigour, which we have talked about a little bit. So one of the things about OPEL and realist evaluation in general is the iterative nature of testing your CMO configurations. You were part of the process for qualitative data analysis, and we also did some comparing of the qualitative and the quantitative findings. And that then led to the consensus event to further test and refine the findings. Could you start by telling us more about your involvement in data analysis and how this was a robust process? Maybe if you describe those meetings and how we did it.
Yeah, sure. The researchers in our team carried out interviews across the case study sites, which produced hours of responses to a set of questions, which had to be analysed against the CMOs that we were steadily developing. The ability to pick out the salient points of interviews was initially very difficult, and in fact required 2 sessions of specific training with some exercises to establish the necessary skill in order to participate in data analysis from a realist perspective. My preferred method was to combine the interview transcripts with an audio recording of the same interview, because this gave me the ability to listen for nuance in the tone used in answering the questions. It was important for me that a standard set of questions were used, because it enabled me to apply the same analytical approach to each interview.
That's a really interesting point, and it relates to the realist theory that there are differences in interpretation of the same data, and that having the different viewpoints of clinicians, researchers, and yourself in the team enabled us to really challenge our interpretations and rigorously refine and review our CMOs. So the researchers, the research associates, we used NVivo to code in detail, but in the meetings we took a more global approach. And because we've been using NVivo and coding the minutiae, we were bogged down in it, but you gave us a perspective and picked up on nuances from the audio that we had forgotten.
Yeah, I recognise that the researchers were doing a lot of other work to get to the end goals. but my unique contribution was that of personal experience and perspectives. Sometimes I felt the researchers had jumped ahead of me, but I realised I had to manage the time spent carefully. However, they always responded to my concerns.
Thanks, Graham. Could you tell us a little bit about the consensus event and your involvement in it?
The consensus events were held at 2 locations, covering the North-South divide. These events were critical to ensure the work we'd done to that point was both understood and acceptable to the audiences, which included a good cross-section of all those interested in the study. The format was that we presented our findings and then posted a series of questions against each of our CMOs, which were responded to by the participants. The output from each exercise was captured to examine the responses against our CMOs, and we found that our findings resonated with their experiences. We were then able to finalise the CMOs with confidence.
Thanks, that's really helpful. It also helped develop recommendations in a way that was helpful for different stakeholders. For example, recommendations specific for hospice at home clinicians compared to managers or commissioners. And that leads nicely into the next stage, which is dissemination and impact activities, which are obviously key with any implementation science approach. And the feedback from the consensus events indicated support for the work we were doing. Could you tell us how things have developed since then?
Yeah, from that work that we did during the OPEL project, significantly, it was felt by many of the people who had seen and sampled the work that it needed to be reformatted into a practical tool, enabling it to be used in a responsive way, tailoring it more to the needs of an individual service. Utilising the CMOs, we have devised a process which will enable hospice at home services to drill down into the data in a simplified and logical manner to create an understanding of how their specific service could respond to the best practices we've identified through our OPEL research project.
Thank you, that's really helpful. Is there anything else you'd like to add about OPEL and the Realist approach overall?
Yeah, what I'd like to say is I know that lay people participation in research is being seen as a positive approach and being encouraged. Realistic evaluation has demonstrated to me its value when dealing with multifaceted, complex qualitative issues, and that people like myself, when involved at an early stage of the research programme, are able to add both diversity as well as value to the work.
Thank you very much for joining us today, Graham. It's been really helpful.
Thank you, Vanessa. It's been a pleasure.
In summary, realism was developed to bridge the divide between positivism and constructivism. The paradigm asserts that things can exist even if we cannot see them, so think of your iceberg, and that the real world exists in an open system. A realist approach is suited to evaluating complex healthcare interventions situated within social systems. So these are systems that are open, complex, and dynamic, influenced not just by the people within them, but broader organisational and policy constraints. So realist synthesis, that's reviewing secondary data, and often the first step of realist evaluation, where you're collecting primary data. Case study design is a popular choice, and I'm referring to Yin's case study design, and it works well in many respects. So Yin is neutral in his paradigm, although he does say he leans towards a realist perspective. And both realist evaluation and synthesis value stakeholder engagement and co-production. So the overall aim is to uncover the mechanisms that lead to certain outcomes, intended or not, in different contexts. And it's important to translate the findings into something digestible and practical for your stakeholders when disseminating and working on your pathway to impact. I hope it's been useful, and I hope the references will provide you with some further food for thought. Thank you very much.